continue on with shoulder injuries. If you were with me a couple weeks ago, we kind of did part one, which went over the anatomy, kind of physical exam, and then just talked about the interplay of, dynamic and static stabilizers and shoulder injuries, the cuff being the most important dynamic stabilizer, and then the static stabilizer being the capsule and labrum and those kinds of things, and how, especially in athletics, when one's a problem, the other one sometimes has to take up the slack, and that's where things start to break down. So today we're going to get into some cases, and hope I'm not sure this will take up the entire time, kind of like last one, but we're starting a little late anyway, so it'll work out. So first case, 17-year-old football player tackled during morning practice on the third day of 2-a-day practices, lands directly on the outer aspect of the shoulder. He's unable to move his arm and comes to your office that day. On exam, slightly overweight lineman, appears uncomfortable, holds his arm in internal rotation, adduction. Difficult to appreciate swelling just because of his size. You don't see any discoloration. There's no obvious deformity. Tender over the proximal humerus and a little bit tender over the AC joint. Just won't move it for you. It hurts too much. Neurovascular seems to be intact. So what kind of things would you throw on your differential diagnosis with this story and at least that initial exam? Okay, so somebody said dislocation, yes. What else? AC joints, sprain, okay. Anything else? Humerus fracture. Okay, so throw fracture on there too. Clavicle fracture, sure. So we've hit some of the severe things. What about less severe? Sprain. Yeah, just shoulder sprain, right? Or just bruised. Okay, yeah, strain, sprain. So what about in this kid? Are you gonna want a X-ray? Okay, most people in the room give me a nod, yes. So what views would you like to get? How are you gonna order it? Y view. Okay, why do you want the Y view? Okay, yeah, so scapular Y view is good for dislocation. There's also another view called a axillary view, which can pick up a dislocation more easily. So there's one view you want. What about any others? Just want one view only? Okay, so yeah, an AP view. You can get a dedicated view kind of down the AC joint, I think, but not typically one that I order. It's got 2 views ordered. Anything else? Anybody have any thoughts? Okay. The third view that usually we get is called a glenoid view. So it's, I think we talk about somewhat on the position of those things, but as we go through here. So differential diagnosis, everybody hit most of those things. Stinger is the other thing thrown on there, which typically an athlete's going to have a little bit more kind of complaints of numbness or tingling or weakness in the arm. But it will be a reason you'll see somebody sometimes come off the field and they're just not moving their arm at all. It's kind of just hanging there limp because they got a stinger. So the views I typically get are a true AP, which is the glenoid view. So it's shot 30 degrees off of sagittal, kind of laterally. AP view is a straight on view, and then they use the axillary or scapular Y view. Axillary view, to get somebody has to be able to abduct their arm about 30 degrees. So if somebody's holding their arm in an adducted kind of position, they won't move it. You're not going to be able to get that. So the scapular Y is a lot easier to take. So this kind of shows the positioning for an X-ray on the true AP. You can see how the beam is shifted, good, 45 degrees from straight sagittal to get kind of the plane of the scapula. So it's 90 degrees of the plane of the scapula, so you can see right through the glenohumeral joint. And then the Y view is shot the opposite way, kind of down the plane of the scapula. And the picture there and shows kind of where you can see the humeral head centered on the glenoid in those images. So I'm only giving you one view, but hopefully you guys can see that. This is our athlete's X-rays. Anybody want to describe what they're seeing? Fracture. We got somebody just said fracture. Okay, so you're gonna call your orthopedist on call and say, "I got a fracture," and they're gonna say, "What kind of fracture?" Okay. Dr. Tim is saying maybe a humeral head and impacted. Slightly. I'd say where do you see the fracture line? I mean, what portion of the bone?
So like greater.
Okay, yeah, so the greater tuberosity is fractured.
I can't tell if it goes like all the way across. It looks like there's a step off.
Mm-hmm. At what point of the bone is that? Somebody said looks like there's a step off in another location. What would you call that?
Neck.
Yeah, the neck. So there's the anatomic neck of the humerus and the surgical neck. The anatomic neck actually is a much rarer fracture, but I don't know. Probably can't see I can't see my cursor, but it goes a little bit more obliquely from the articular surface. But the surgical neck is the one that goes straight across. What we think about most of the time is calling the neck. So there's a non-displaced fracture of the neck of the humerus with a fracture of the greater tuberosity. Would you say that fracture is displaced or non-displaced? Yeah, looks like it's pushed out of position, right? You see some step off there, especially superiorly between the top of the humeral head and where that thing should be. So. All right, so when you're talking about, in this instance, at least the greater tuberosity fracture along with the surgical neck fracture, there's this near classification system for proximal humerus fractures. It's defined by the number of parts. Each part can be defined basically by if it's angulated more than 45 degrees or displacement of a centimeter or more. So there may be more pieces, so you could have still a crack, crack is 2 or 3 cracks in the area, but if everything's, non-displaced, then technically that's a 1-part fracture. Does that make sense? So it has to be displaced in a certain amount, either angulated 45 degrees, displaced a centimeter to be considered a part. So the problem with that is I even talk to my orthopedic colleagues and they're looking when I say, oh, that's a 3-part fracture, but it's like, well, only 1 part's really moved more than a centimeter. So, there's certainly some poor inter and intra observer reliability in that classification system. But this is a picture kind of showing the really bad ones that you can come across of the greater tuberosity, lesser tuberosity, these fracture dislocations. I mean, some of those down there in the fracture dislocation pictures, like, it looks like a yard sale. I mean, stuff's just thrown out everywhere. There's pieces all over the place. So honestly, the ones I take care of don't ever look that bad. They don't end up with me. They usually get caught in the emergency room and likely gotten to an orthopedic surgeon before they get to me. But that's just a good kind of summary and pictures of the different types of 2-part, 3-part, and 4-part fractures. So one of the things you're trying to decide, like how much angulation do you have? The normal neck to shaft angle, so say you draw a line down through the center of the femoral head and then make an angle down the shaft is 135 degrees. So it's not a straight up, ball sitting on top of a post. It actually angles a little bit at the end. And so that's a way that you can kind of determine how much angulation you have. So how would you classify this fracture? So there's a crack across the neck, the greater tuberosity fracture as well. What would you call that one? Is that a 1-part, 2-part, 3-part? Yeah, somebody said 2-part, which is correct. Because you have that greater tuberosity fragment. I haven't measured it, but it looks like it's displaced at least a centimeter and likely is. And certainly a young athlete with that amount of displacement, you probably can't just let that be there. That's going to limit motion. That big fragment's going to have a hard time clearing underneath the acromion as he abducts. So you're thinking maybe surgery, but you're not a surgeon, so what are you going to do with them? Can put them in a cast?
Probably just splint them until you sling.
Okay. Splint or sling?
Sling.
Okay. Yeah, sling. I mean, there's really not much you can put around the upper part of the humerus to take care of that. So what if there's just a 1-part fracture, so nothing's really out of place? Do anything different? At least initially? Yeah. People shaking their head, nope, do the same thing, right? So you can put them in a sling. So really, 1-part fractures, which are the ones I think, honestly, family docs can take care of. I take care of a lot of them. None of the fragments are displaced more than a centimeter, or angulated more than 45 degrees. You put them in a sling first couple of weeks, and then you can start to actually get them moving once the head and the shaft kind of move as a single unit. So I let them start to do some Codman's pendulum exercises. at about 2 weeks, which is just letting the arm dangle and just some small movements in circles, counterclockwise and clockwise, and then you know, side to side, front to back. Usually by 6 weeks, which is where you're going to see some new bone formation, then you can have them start to do some active movement, you know, firing their own muscles to move the humerus. And a lot of times at that point, I'm getting people into physical therapy because usually it's pretty stiff and weak and hard to move. And they usually progress them to strength thing based on, you know, once their motion's getting better. And really most people do quite well. About 10% will have a poor result, but, you know, greater than, you know, 75% have a good to excellent result. But you always have to kind of lay the crepe. I mean, most, you know, this was a case of an athlete, which you don't see these in athletes, honestly, that often. Probably the population you're going to see these more often is the elderly population. And I always tell people you're going to have functional motion, but probably not full range of motion if you had full range of motion before this injury occurred. So, functional meaning you can, you know, get your arm probably to here, be able to reach the top of your head, do your hair, you know, feed yourself, those kinds of things. But you're not going to reach a really high shelf, you know, way up, you know, something up really high with it. So common fracture you'll see, but fortunately not that common in athletics. Questions on that one? Okay, 12-year-old male baseball pitcher comes to the office complaining of pain with throwing. It's gotten progressively worse. There wasn't any injury. No pain at rest. On exam, normal motion, ab and adduction, has some increased external rotation and decreased internal rotation compared to the other side. Strength is normal, empty can's fine, negative Hawkins impingement. There's no laxity at all when because you're so astute in your exam and checking load and shift and making sure they don't have a lot of capsular looseness. Slight tenderness on the lateral deltoid when you push there, but that's pretty much the only remarkable finding that you get on this kid. So what about this 12-year-old with just a sore shoulder from throwing? Doesn't remember anything. That exam. Okay, so Dr. Tim mentioned stress injury. What else might be on your list?
I mean, could you still have an injury going on, like just specifically with throwing motion, but not like he's not inflamed right now, so Hawkins would be negative? Yeah,
no. So Lauren said, can you have some impingement just with a throwing motion, even though you can't really reproduce much there on exam? And I would say certainly, that's definitely possible. So could be getting some impingement with that abducted, externally rotated position. What else might you throw on the differential? I think it's just maybe one other thing I might have pretty high on there. Say the kid's been playing summer ball and now that's crossing over into some of maybe, he's thrown most, at least weekly for the whole summer. So wrapping up. Okay, so Warren said maybe a slap tear. Yeah, throw on the list, although I haven't seen one in a 12-year-old. What else? I'm just kind of thinking more overuse. What might you throw on there? Besides a stress injury, something else that would get overused in a thrower. Okay, yeah. So rotator cuff tendonitis, might just be inflamed cuff, right? So you're gonna get an X-ray on this kid? Good question. I can't remember. Progressive. We'll say it's going on for about 3 weeks now.
It probably would be normal, but if you had like beginning signs of a stress fracture or something, probably wouldn't see it this early. But let's do it.
All right, got some people saying no. Got a couple guys here saying let's do it. So, yeah, I don't know that you could be faulted necessarily either way. I personally would tend to, and you'll figure out why based on when the case plays out. But so things listed. I mean, in a kid, certainly anybody could throw on tumor infection, but I think you guys hit the main things on the differential. If you got X-rays, we're kind of probably get the same views we got before. So in this instance, we got X-rays, and because of some of the things we were thinking about, we got a comparison view too. So what do you guys see there? He's a right-handed thrower. Yeah. So you guys can see the proximal humeral physis there, how it looks wider there on the right side, his throwing side compared to left. So, you know, certainly this kind of confirms what you're thinking, which is a repetitive stress injury of the proximal humerus. So the thing about a kid is that, you know, in an adult or you know, a skeletally mature thrower, you know, the cuff, the labrum, those kind of things tend to be the weaker links in the chain. But in a kid, it's actually the proximal humeral physis. And so it's just something you need to think about in a young thrower that you wouldn't think about in somebody who's skeletal mature. 80% of the time, they're going to have tenderness over that lateral proximal humerus, kind of in the deltoid. And then most have some radiographic evidence of physeal widening. And it can be pretty subtle. So you always got to get a comparison view if that's what you're at least thinking about in your athlete that you're taking care of. So the treatment's simple. You just rest from throwing. Unfortunately, it takes a while, and a kid that's playing a lot, you know, and most of the time the kids that have this issue love baseball. They're throwing all the time, throwing in the backyard with their dad, you know, maybe playing in a couple different leagues. And so it's really hard to shut them down. Get them on some NSAIDs, you know, I'm doing some scapular stabilization exercises and core stuff, and, you know, work on everything else around the shoulder, but just kind of let the shoulder rest and chill out. I do, once they're feeling better, if they still have enough season left that it makes sense to return, I tell them you really shouldn't pitch the rest of this season. Next season you can, but it just doesn't make sense to pitch. And catcher probably throws just as much, if not more, than a pitcher, so I try to discourage that position as well. The big thing with this is just prevention, limit pitch counts, you know, try to keep them throwing a breaking ball until they're over 14 and making sure kids are working on proper mechanics. Fortunately, there's a lot more awareness about that in leagues these days, and so most places have pitch count restrictions on kids already. So that's definitely been a nice change over the years. So as far as like following this up, I don't usually go by radiographic appearance at all. I go based on symptoms and time. So their symptoms will feel better real quickly. I mean, because they're not throwing at all. They'll come and say, I'm feeling fine. My push on the shoulder, it doesn't hurt. And they're going to want to throw. And you just got to say, well, you just need to give this enough time, because if you start pushing this early, you're going to be right back to where you were. One of the things you can make sure you get them back into is just once they're starting to throw again, is a throwing progression. You can have the trainer, coach, parent supervise this. Honestly, you can print these things out off the internet. You can Google a throwing progression, you'll find a bunch of them. So they have to have kind of good motion on exam, pain-free, adequate muscle power, and adequate resistance when you're examining them. I'm going to blow through this pretty quickly, but basic programs kind of go through this, start at a shorter distance, go to increasing distance, and then eventually progress to off the mound on a pitcher. So any questions on that? All right, move on to case 3. 45-year-old female tennis player serving and felt a searing pain through her shoulder. Said it felt like a hot poker jabbed me in the shoulder, unable to continue playing. On exam, complains of poor motion, pain, especially trying to raise the arm, denies any paresthesias or neck pain. On exam, she looks fine, not in severe pain, tender at the cuff insertion, active range of motion to only 20 to 30 degrees of abduction and forward flexion. Passively, you can move her up to almost shoulder level before it hurts. Positive drop arms test, positive Hawkins impingement sign, negative speeds tests. You guys remember what speeds tests? Biceps, correct. Unable to do empty can, but has pain and weakness with external rotation, no pain with internal rotation, and seems to have good strength with internal rotation. So what about this middle-aged tennis player? Any X-rays really needed on her? Got a no. Non-committals, mostly no's. Okay. What things are you thinking about? Maybe a little, obviously no trauma, so things like a fracture and other stuff seem a little bit less, would be way down on your differential, unless there's something pathologic going on. Okay. There's slap tear thrown out there. What else did you say?
Just a acute
rotator cuff tear. Okay. Anything else?
Yeah.
Impingement. Okay. Okay. Yeah, I think that's a reasonable short list. You know, probably top couple of things is just either strain or tear. She felt something happen, right? Was doing fine, and then felt this kind of hot poker sensation. So if you want to, you know, if you're really wanting to like take the time and try to figure this out here in the office with little cost, so you're not going to get imaging. But what could you do to try and figure out, is this, is this patient's poor motion and weakness because of pain, or is it because you just, there's something that's not connected? What kind of diagnostically might you consider in the office that could help you out? Okay, so that's relatively inexpensive. Ultrasound was said, so I'm sorry, I got to repeat these things. Relatively inexpensive imaging that you could do in the office, correct? I was thinking about something else that you could do too. You could do it.
Oh,
go ahead.
Like inject like an NSAID. Yeah.
Yeah, so you could do like a subacromial, bursa injection around the tendon and see if that eliminates pain, and then if you get the pain eliminated, what, if their strength and function improve. So in this case, tried that, still poor strength against resistance even without pain, so you're pretty suspicious of a rotator cuff tear. So what are you going to do with this lady? And you get this pretty commonly. What are your options?
MRI.
Okay.
To investigate whether or not it's full thickness.
So one person here mentioned MRI, certainly something you could do. What else? Just happened, right? So.
Physical therapy.
Okay. So you could, somebody mentioned physical therapy, sort of give it a little bit of time, seeing how she progresses. Also a reasonable choice. Okay. So yeah, I think that's your choice at that point, right? And, I don't think there's necessarily a right answer on that all the time either. I will say, based on my experience, I've had times, first thing in the office, I think, man, this person's got a cuff tear, I'm convinced of it. And they show up two weeks later and they're doing tons better. And surprising me quite a bit on how much improvement I've seen in their pain and function. So certainly there's there are those that come back and they look exactly the same as they did initially. And those are the ones I'm certainly more confident. So yeah, I think you can go with a kind of tincture of time and rehab option in most cases, and hold off on your MRI unless somebody's just really pushing or has a big reason they need to know right now. So get them working on their motion, NSAIDs, ice, reevaluate within 2 to 4 weeks, and then to kind of see how they've progressed by that point. So I think that's probably most cost effective and most reasonable way to do it. Ultrasounding certainly can get you that information much more quickly than otherwise. So rotator cuff tears concur with blunt trauma, typically on an adducted and internally rotated shoulder. More commonly, they're kind of chronic attritional things that happen. People can tear their cuff as you get older from doing just your normal daily stuff. They'll feel something happen when they're doing something pretty mundane. Many rotator cuff tears can do well without surgery. Patients who fail conservative treatments, which are typically steroid shots, therapy, those kinds of things, after 4 to 6 weeks, may need surgery. If they have severe pain, progressive weakness, then in those instances, I get an earlier surgical consult than I might most of the time. So again, ultrasound, MRI imaging is good to get kind of nail down your diagnosis. So you'll see lots of rotator cuff tears, guys, in your office, tons over your practice. Shoulder pain is a common thing that's going to, in a primary care practice, that you're going to see people come in for. So fortunately, most of the time you can try the rehab side of things first, and then pull the trigger on imaging if they're not responding. Questions on that? Okay. Next case, 21-year-old female playing basketball, dives for a loose ball, feels her right shoulder slip out. Presents to your office the next day, pain with movement. So this has never happened to her before. She couldn't play after the injury, but didn't go to the ER or anything. She was also a swimmer when she was in high school. On exam, she's tall and thin, seems fine. Arms hanging on her side comfortably. You have her move her arm, and she can move it through a full range of motion. Her strength's good. She hyperextends at the elbows and some of her finger joints as well. When you try and shift her shoulder around, she's got kind of 2+ anterior laxity, 1+ posterior on the right side, and then just 1+ on the left. And then it's positive sulcus sign bilaterally with a positive apprehension test on the right. So things are, what do you think's going on? I mean, with that story and that exam? Okay, so hyperextension, which is kind of the mechanism. What happened when she said it slipped out? Do you think it truly slipped out? Yeah. Right. Yeah. So it seems like she's got some lax joints anyway. Probably partially came out and slipped back in, which is called a subluxation, not a dislocation. So it didn't probably come all the way out. But when somebody feels like their shoulder shifts, it probably did. I tend to believe them most of the time because the shoulder has, it's a bump, it lacks stability for the motion that you have. So subluxation is defined as a minor disruption of the joint. Articular contact remains. They typically occur in the presence of some baseline ligamentous laxity or shoulders that have had either repetitive microtrauma or some previous injury that caused some loosening of the capsule. So you have rotator cuff weakness and poor dynamic stabilizers on top of that. That's going to contribute to your shoulder shifting around. So what are you going to do with this young athlete who just had her shoulder shift once, but already seems to have some pretty good motion and function, just hurts a little bit? Any thoughts? What's your...
Maybe just focus on strengthening like her shoulder musculature. I don't know. It seems like from what you gave with the details, she might have like some kind of connective tissue thing going on too. Okay. She's got like chronic instability bilateral.
Mm-hmm. Yeah. So mentioned probably work on the strength and shoulder stabilizers, and it seems like this athlete might have some, mixed connective tissue disorder or something that could be contributing. So, what if she asked the question of, do I need surgery? What do you think? Do you think that's the first thing to go to, or okay? How come? So I got people just shaking their head, no, don't go to surgery. So, any reason behind that?
What would they do?
Okay. So the question was, what would they do? Well, yeah, I think that's certainly the challenge. So when somebody has a loose shoulder at baseline and it's kind of slipping out and they seem to be loose in multiple directions, you're correct. If you're thinking like a surgeon, well, what am I going to tighten up? How am I going to keep this from happening again? So, and that's the difference between somebody who's had a traumatic dislocation and somebody who's had, just kind of instability or multidirectional instability. So those are the two types of shoulder instabilities that you're going to come across. There's the traumatic unidirectional instability, and then there's the people that have kind of a loose, kind of sloppy shoulder that'll kind of sublux or move around. And then the management is much different, and the things you see are much different too. When you have a traumatic dislocation, they almost always have what's called a Hill-Sachs lesion, they can have a Hill-Sachs lesion, which is a fracture at the posterior lateral corner of the humeral head when it comes out and then kind of knocks against the edge of the glenoid. And you will always see a bank heart lesion, or almost always, where the labrum capsule tears anteriorly. Sometimes you'll get a bony fragment that can happen with that, which would certainly make you have to have that athlete see a surgeon a little more quickly. So the force, when you see the Hill-Sachs lesion, it tells you there's probably been greater force, and it can be associated with more chance of dislocating again. So these are some pictures of what those look like. You can see the big divot on the humeral head on the picture on the left. And then you can barely see a little notch there that's kind of pointed out a little bit better in the drawing below of a bony bank heart lesion on the inferior aspect of the glenoid. So traumatic dislocation, the redislocation risk is really highly age dependent, and a lot of that's due to the activities people are involved in. Below the age of 30, really high chance of redislocation within 2 years of your initial injury. If you're above 40, that risk is almost, flipped. So, I tend to be people like the worst case scenario would say 90% chance comes out in the next 2 years. If you're over 40, it's only 10% it comes out in the next 2 years. So those are easy numbers to remember. So there's a lot of question of, do you fix first-time traumatic dislocators? There is some reasonable evidence out there that multiple dislocations can cause arthropathy. The cartilage surface can die, and people can get, shoulder arthritis at an earlier age with multiple dislocations. So people still, continue to debate whether or not to fix first-time dislocators. I always think if it was myself at that age, I'd probably roll the dice and hope I'm in the 10% that doesn't happen again, or 30% that doesn't happen. second time, you know, I would probably more strongly consider fixing it. So I always inform the patients of the risk and let them make the decision. Sometimes they don't want to go through that again. So when you have a traumatic dislocation, the question is, how long do you immobilize? What position? There's some small studies years ago that had them immobilized in a kind of an externally rotated position with a pillow. Can't really get on the screen, but like out here with a pillow kind of holding it there. Those were done out of Japan. Really, the compliance is pretty, you know, I find to be very hard to accomplish, and there's not many people doing it. We don't really know how long you need to immobilize somebody. You know, external rotation position may prevent recurrence, but I usually just use a sling for comfort, and then after a week, 10 days, I get people moving the majority of the time, and I let people get back to play, especially in season when they have full range of motion, full strength, and you might consider, you know, putting them in a brace to finish the season. These are the braces that are out there. Again, we're talking about traumatic dislocations. Sully sleeve Duke wire brace. We use one called an armadillo. And actually has a picture of an armadillo on it, which is kind of cool. But they all limit your ability to get your arm up into this abducted and externally rotated position. So there are some sports, you know, in basketball, you can't reach up and grab a rebound. You know, they can become a little bit limiting on what they can do. These are easy to use on somebody that's on the line. You know, in football, you know, a check rein and position actually is something you can accomplish pretty well. But sports that require more shoulder motion, they're harder to get to work and comply with, so that they can still do the requirements of their sport. So the other group is the kind of the case we have, which is the multidirectional instability. They have increased failure rates with surgery. Most surgeons prefer at least a year of physical therapy prior to considering anything operative. Thermal capsular shrinkage was something that's in play years ago. Really don't do that much anymore. So the most common procedure now is just an inferior capsular shift if they ever get to surgery, but I would tell you most surgeons really drag their feet before considering that at all. So kind of summarize with instabilities, traumatic, at least consider surgery. Immobilization and external rotation may decrease recurrence, but most of it's based on age. And if somebody's trying to finish their season, once they have full range of motion and strength, you can get them back, but consider a brace if it seems, you know, doable. And then if they're atraumatic, multidirectional, kind of loose jointed athletes, just keep rehabbing them. So with rehab, you know, make sure you don't just rehab the cuff, focus on the scapular stabilizers, core muscles. These are just some pictures of like push-ups and chair press-ups to kind of pinch the shoulder blades together to try and work on scapular stabilizing X-rays. And again, you can access some of these exercises with a Google search as well. So, any questions on instability? Okay. Move on to case 5. 15-year-old soccer goalie dives to deflect a shot on the goal, hits his shoulder on the post, felt a crunch, complains of pain and swelling in the shoulder, notes pain with trying to reach above his head or across his body, no previous injuries to the shoulder whatsoever. And nice picture there on the right, swollen on top of the shoulder. There's some deformity, tenderness of the AC joint, distal clavicle, can actively abduct and forward flex to about shoulder level, and reach across his body on the AC compression test is pretty uncomfortable. That's pretty good strength, just slightly weak because of pain. So you saw that in your office. First of all, would you want an X-ray? Most people are nodding yes, which I'd agree. There's trauma, that look, get a picture. What things are in your differential diagnosis? Just give me your top 2. Okay, got AC joint separation thrown out there. Clavicle fracture. All right, perfect. Exactly what I would say. So get an X-ray. Fortunately, we have a nice picture to the next to that X-ray. But so what is that? Does anything look broken? No, nothing broken there. So this is a AC joint sprain. So again, kind of reviewing the anatomy of the acromioclavicular joint, there's ligaments that connect between the tip of the clavicle and the acromion, and then also some ligaments that come off the coracoid process that go up to the bottom of the clavicle that can be injured. So with AC separations or AC sprains, there are several types, actually 6. These are all kind of explained here, which a lot of verbiage and picture does better. So a type 1 is basically that everything's intact but just been stretched a little bit, so it's sore, but everything lines up. A type 2, you injure the acromioclavicular ligaments, but the coracoclavicular ligaments are intact. A type 3, you injure both of those sets of ligaments, and so you don't see congruity or see marked incongruity between the acromion and the clavicle. And the clavicle really stays stable. It's your acromion that sinks down because of the loss of the stabilization forces. So so that type 3 would look like this as far as a step off. A type 4 is actually the clavicle gets pushed back posteriorly into the trapezial fascia and into the trapezius. I've seen one of those. It's kind of weird when you feel the clavicle back that far. And then a type 5 just looks like a really bad type 3. So the fascia, in addition to the ligaments, has been torn. So say a type 3 might look like this. A type 5 is going to be a much wider separation on your X-ray. And then a type 6 is where the clavicle gets pushed down underneath the coracoid, and I've never seen one of those. So what's the big deal? Why do you need to know that system or that, know the types of that injury? Well, types 1, 2, and 3 tend to be non-surgical. And then if you got type 4, 5, and 6, that tends to be fixed operatively. So it's just a nice line of demarcation to decide, does this person need to see a surgeon or do they not? Type 3 is kind of a gray area. Most do well without surgery, and most surgeons kind of encourage non-surgical treatment. But there are certain instances where they don't want the, the cosmetic deformity there that's going to persist. There may be a high demand, overhead athlete or a high demand worker that has to lift and push a lot of things where they might choose to fix it. So again, types 1 and 2 by far, no surgery. They can get back to play sometimes earlier than 3 to 6 weeks. It all depends on their sport and their function and how much discomfort they're in. But similar to an ankle sprain, they can return even though they're a little sore as long as they can function well and do the things required of their sport.
Are all those staging, is that staging all possible with just the plain X-ray?
Yes. Yeah, you don't need advanced imaging at all. I can't think of many AC sprains that I've done any advanced imaging on whatsoever. So you can just base that all upon X-rays. You will see people, mention like weight, like stress views where you hold a weight and you can determine how much separation you're getting. Honestly, I don't find those that helpful. If it's a type 3 is going to have that offset. A type 2 will just have a little offset. I mean, honestly, trying to stress a type 2 and make it a type 3, not likely you're still going to change your management at all. So I don't usually routinely get stress views at all, but it's something that you'll read. If you read up on these things, you'll find it mentioned at least.
So where are you measuring for the displacement, 2 centimeters of displacement? Is it like from the acromion to where the clavicle is? Like, where are the best places to mark that?
Yeah, I would like, normally they'd be lined up end to end, right? So I'd be measuring from the top of the clavicle to the top of the acromion, going from your displacement from anatomic position where it should be to get your 2 centimeters. Other questions people might have? All right. Well, that's the cases I got. Like I said, wouldn't take up the whole time, but shoulder in one talk was just way too much to do. So I split it up into 2. All right. Well, I should be back here in a couple weeks. I don't think I've chosen a topic yet. It'll be a surprise. So thanks, guys. Zoom clap. I got a Zoom clap.
So random question about football players.
Yeah.
The brace that I see so many of them wearing on their bicep, upper arm, what does that for or do? Like I know Charles Tillman wore it. I see a lot of defensive backs wear it. It's just like around the entire upper arm.
Yeah, you might be seeing the bottom of a brace potentially.
Okay.
Because I like the armadillo brace that we use has a strap that comes all the way down to here. So maybe they've dislocated or had some instability before. I mean, the most common positions that you see that in football are honestly your linebackers and defensive backs by far.
Okay.
I mean, that's
Probably just keeping them from.
right. Getting out of that far abducted external rotation position, but that's
like if you're tackling someone.
right. Yeah, so that's probably what you're seeing. It could just be for looks. So some compressive garment that you can just kind of see sticking out there.
I'm assuming you saw Dak Prescott's injury.
I did.
Did you watch it live and listen to Tony Romo's commentary?
No, I just saw the replay.
So as he's going down and rolls over, and you see that his foot is pointing the wrong way, Romo goes, "Oh, you're a Cowboys fan. You just gotta hope it's only a cramp."
Yeah, looks like a cramp, doesn't it?
I was coming back from the class I was teaching, and I like look at the score. I'm like, finally, Dallas is doing some good. So I pull up, and it's right when Dak goes down. Like the second he goes down, I'm like, no.
You got a red rifle though. You guys are good.
I was excited to have him as a backup.
I mean, he's a good backup.
Yeah. I lost by 0.44.
0.44.
Yep. Cooper, how was the wilderness medicine thing?
It went without a hitch. So good. Turns out, like, Ken Hansen that gave our team conference on Friday, he starts his like altitude lecture with like, now the last time I was in Antarctica. And I'm like, okay, this is gonna be cool. And then he's like, his dive medicine lecture, he kept throwing all these stories about now this time I was treating a Navy SEAL and like, yeah. And the other two are like, they're both like certified. They both done like a fellowship for wilderness medicine. And they're both practicing ER. So they brought kind of.
Yeah, most, I feel like you can really express a lot.
It is, yeah. I'm trying to like buck the trend, but it's like, like
So bummed that I missed that.
you ask med students, and so what are you interested in? Well, obviously ER. I'm like, anyone can come to these. Like, it's